I welcome you all for our final concluding session of the E-Gurukul Icon Amrita series. So this session is on drugs used along with radiation on radiosensitizers. So for the new audience and the faculty, we've been doing this for the last 4 months, and we started in January, and this was done for the benefit of students going for their examinations, especially the DM and the DNB medical oncology. So it has been quite a hit with students, and they keep asking for newer sessions, but unfortunately we'll have to conclude with this 18th session. But yes, definitely we'll come back stronger. So next slide, please. So for today's session, our program director is Dr. Purvish sir. Sir is President Asian Society, Asian Journal Oncology Society, and sir was previously professor and head Tata Memorial Hospital, Mumbai. So sir has gratefully, agreed to join us from New Zealand, especially for the benefit of students. So over to you, sir.
Thank you very much, Karan. Thank you, Rajan and Meena, for joining us. 4 months ago, Karan actually sent me a message with the idea that we should do this on a weekly basis for drugs, especially for exam going students. And I was a little skeptical at that time as to what was in his mind and how it is going to be benefiting. And I actually, gave him some thoughts. Okay, are you really, thinking that this is going to be of value? But all my hesitation and my skepticism has evaporated. Over the last 4 months, he has made sure that each and every session has been really great, and it has been a excellent learning as well as mock examination experience for the participants. So both Karan and Prashant Mehta, I congratulate you for taking up this initiative. And it is not an end to it. All the recordings are available on YouTube. So anybody can go and revise it as and when necessary. And Karan, in his fertile mind, will continue to bring out new innovations. I must also congratulate Karan for being selected and has joined Tata Memorial Center as one of the consultants. So RTS, congratulations to you, Karan.
Yes, sir.
I don't want to say anything about the specific topic of today's webinar, but it is really my privilege to introduce Dr. Rajan Yadav. We have been associated with for some time now in a lot of academic activities. And Rajan is associate professor in medical oncology at Ahmedabad. But more than that, he is always, thinking outside the box. He has a lot of innovative ideas, and he has a lot of interest outside of oncology, but related indirectly to healthcare. So I'm sure that all of you will benefit immensely from what Rajan will do as part of his moderation. And so without wasting much time, I hand over to Rajan to carry on with the proceeding. Please go ahead.
Thank you so much, sir.
So thank you, Karan. Like Sai rightly pointed out, you are a tour de force, and your energy is in fact contagious. And it's always an honor and privilege to speak after Saib. So I would not do the sin of introducing Dr. Chetan Deshmukh because we all know him very well. It would be like showing light to the sun. But I'll take some time to go through to introduce Dr. Meena. I'll call her Meena here on. She first sent across her slides to me. I thought that I'll have to put in a lot of effort because I checked her background and she was an MD in medicine. And being a career radiation oncologist and now into medical oncology, I thought I'll have to spend some time with her explaining, trying to tell her what 5 hours and now 6 hours of radiation oncology are. But the first set of slides she sent to me was shocking. Very few in this country, I can name them, Dr. Shalin Kumar, Dr. Manoj Gupta, have that kind of understanding of radiobiology that Meena demonstrated in her slides. And thank you, Meena, for that. It was taking me back years. And for the students, cisplatin is a drug in which you cannot fumble. If you are not able to say something about this agent Lucille in your exams, you'll be excused. But cisplatin is the holy grail of oncology. It's the cheapest, the most used, and the oldest drug, except 5-FU and methotrexate being an exceptions. Cisplatin came in 1967 and was started used. They started to use it along with radiation in say late 70s, and it's still in vogue and it's still the drug to go to in almost all malignancies. So I'll have some remarks once Meena finishes, and till such time I'll hand over the mic to Meena. Thank you so much.
Thank you, sir. Ma'am, you have to unmute. Yes.
Am I audible?
Yes, you're audible now.
Yes. Thank you, Dr. Rajan, for your kind words. And you were right. I am basically from a general medicine background, and it took a lot of effort to understand. And more than a teaching experience, this was a learning experience for me. So thank you for this wonderful opportunity. And I would like to extend my special thanks to Dr. Sujana Priya, Dr. Praveen, along with Dr. Rajan Yadav for their valuable inputs. So we've always known that radiotherapy is an effective treatment for cancer. Even in the curative settings, it provides a very good local regional control. And even in the extensive metastatic setting also, we use radiotherapy for pain, palliation, and even controlling bleeding. And it has played a significant role in the management of several malignancies like breast cancer, lung, prostate, cervix, head and neck, etc. So
We cannot
what
see
is
your
the
slides.
principle? Pardon?
We cannot see your slides.
You can't?
Yeah, please can you reshare it?
1 minute. I think my screen sharing has been.
Rahul, can you share the screen for ma'am, please?
No, I'll just share your slide.
Yeah, please. Okay. Next slide. Yes. So, like I have told you, radiotherapy, we have ionizing radiation. In radiation, we have ionizing and non-ionizing radiation. The non-ionizing, which we see in our day-to-day life, the microwaves, the radio waves. But what is of importance for us in cancer treatment is the ionizing radiation, which has particle beams, alpha particles, beta particles, neutron beams, proton beams, X-rays, and gamma rays. So how do these affect the cancer cells? They affect directly, they can cause DNA strand breaks, which are single strand breaks or double strand breaks, thereby causing a mutation, malignancy. Or indirectly also, they interact with the water molecules and form reactive oxygen species, which interact with the DNA and result in DNA breaks, thereby causing apoptosis and cell death. So this is what Dr. Rajan was mentioning about the 6 hours of radiobiology. It is important for us medical oncologists to understand why radiation is given the way it is. Why is there fractionation? How do they dose? How do they plan it? It is based on these principles, which is radiosensitivity, repair, repopulation, redistribution, reoxygenation, and reactivation. The radiosensitivity of a tumor cell is higher than a healthy cell. It's because the repair mechanisms, when reactive oxygen species are formed, our body's natural effect to counteract them is more in the healthy cells, whereas the tumor cells lack this mechanism, because of which they are highly sensitive to the damage of radiation. Likewise, repair. Our single strand and double strand repair mechanisms, like the homologous recombinant repair mechanism, these are all intact and fully functioning in the healthy cells, but they are all impaired in the tumor cells, because of which once radiation causes damage, the cell will not be able to repair itself effectively, thereby the effects of radiation can be seen. Repopulation is a mechanism where we also have to understand how cancer cells grow. What is the growth pattern they follow? The Gompersian growth curve, where initially when the cells are less in number, they divide very rapidly, use up the nutrients. And once they reach a stage of equilibrium where the nutrients and all are in balance, they reach a plateau stage. So when we hit with radiation, some cells die, the number of cells come down, and again they start rejuvenating at a rapid pace. That is why they fractionate it accordingly so that they hit all those dividing cells at the appropriate time, making radiation more effective. Redistribution. This is based on which phase of the cell cycle the cells in. At any point of time, all the cells in our body are not in the same phase. And we know that different phases have different radiosensitivities. For example, the G2M phase, the mitotic phase, where the cells are actively dividing, that is more sensitive to radiation. The G1S phase, where the cells are actually collecting the material to divide, that is a radio-resistant phase. So when one fraction of radiation is given, the cells in the radiosensitive phase will die. But once a gap is given, the cells which are not in the radiosensitive phase, which are in the radio-resistant phase, will move to the sensitive phase, and then the next fractionation will kill them. Then reoxygenation. We have reoxygenation is because the tumor also will have vascularity, but the blood vessels are not as stable as the normal blood vessels, because there will be faulty formation and there will be, it's not a very stable structure. So part of the tumor receives proper vascularity and part of the tumor is hypoxic. And hypoxia has natural radio resistance. The cells which have vascularity are 2.5 to 3 times more susceptible than the hypoxic cells. So once we give one fraction of radiation, some cells which are actually having adequate vascularity, they die. And then the cells which are hypoxic will have vascularity sufficient enough for them to become susceptible. And reactivation. Once the tumor cells are killed by radiation, antigenic release happens and the body's immune system can get reactivated because of this. This will have effects both locally as well as systemically. This is what explains the abscopal effect also, because when the antigens are released, our body's immune system gets triggered, and it may have an effect on some micrometastatic cell which is present at a distant area also. So these are the 6 hours of radiobiology, based on which the sequencing, the type of radiation, all of these are interdependent. It is important for us also to understand this, because it will help us understand why we are giving the chemo that we are giving, why we are not giving any chemo. When we know that chemotherapy will work on those tumor cells, why are we not attempting any and every chemotherapy? Why we are giving only certain chemotherapies? Those we will understand better when we have understanding
Ma'am,
of
really,
this radiobiology.
ma'am, sorry to interrupt you. Ma'am, since we are sharing the slides, ma'am, can you say next slide? So we'll go to the next slide.
Sure. Next slide. I'm sorry that you had to listen to all of that without this pictorial depiction. But yes, that is the radiosensitivity, repair, repopulation, redistribution, reoxygenation, and reactivation. Next slide, please. Yes. So now that I have told you what makes a cell susceptible, what makes a cell resistant to radiotherapy? Obviously, when we have spoken that a tumor cell has faulty DNA repair, hence it is more susceptible. When the DNA repair genes are increased in number, that is when we have radio resistance. Likewise, apoptosis, when there is increase in anti-apoptotic genes and decrease in apoptotic genes, there will be inherent radio resistance. Hypoxia, as I have mentioned to you, it is 2.5 to 3 times less effective actually than a normal vascularity, than a cell with normal vascularity. The immune system evasion, that is the current hot topic. The immune system evasion with genes like PD1, PDL1, CTLA4, TIM3, LAG3. So those also play an important role in radio resistance. The plasticity of the cell, where there is increased transition of the cell from epithelial to mesenchymal component, that also will cause radio resistance. We know that a cell which is of mesenchymal origin, for example, sarcomas, they are not very sensitive to radiation. That is because it has a different sensitivity as compared to an epithelial cell. So if the cell is having high plasticity, then there will be inherent radio resistance. Increase in the signaling pathways like Notch1 pathway, PIK3 pathway will increase the cellular survival rate and cause radio resistance. Likewise, repopulation also will cause significant radio resistance. Next slide. So the point of projecting this slide to you is to make you understand what is the effect of radiotherapy on the body. So when a part or a tumor is subjected to radiation, within the first few hours, there will be an initial response, which is the direct and the indirect effects, which can be either direct or indirect. As I have told you, it can be double-stranded DNA breaks, single-stranded DNA breaks, or the formation of reactive oxygen species and reactive nitrogen species. Because of this, there will be inflammation and tissue proliferation, which is usually reversible at this stage. This is the initial response. Then within the few days to few weeks, when the damage and inflammation will go to a peak stage, there may be acute side effects. When a normal tissue is also exposed to radiation, they will have acute side effects at this point due to damage and inflammation. Then as the body tries to repair itself and remodel, which happens over a period of months and years in the form of fibrosis, atrophy, then we will see the late complications and late side effects. It may also cause vascular damage, infertility, and second malignancies. Why is it important for us to understand this spatial or this temporal scale? What happens immediately, what happens later? It is for us to introduce any radioprotective drugs. So sometimes we will have to counteract the normal tissues from this toxic effects. For that, what radioprotective strategies can be used depends on when the radiation was given. So these are radio modifiers, which are the drugs which alter the response of tissues to radiation. Radioprotectors are usually given pre-exposure or during exposure, because just when the radiation is given, we have to reduce that acute damage. At that point, to counteract it, we give radioprotectors. Radio mitigators are the drugs which are given post-exposure but before the development of symptoms. So we know that the radiation is given, we are anticipating a toxicity, but we want to reduce the toxicity, for which we give radio mitigator drugs. And radiosensitizer drugs are given for the purpose of enhancing the toxicity of radiation and enhancing the cell kill. Next slide. So this is the radioprotectors, radio mitigators, and radiosensitizers that I have talked about. Next slide. So talking about radioprotectors, what is the mechanism? See, when I'm talking about the drugs that interact with radiation, we have to talk about the ones that interact positively and negatively also. So this is about radioprotectors. How do they work? They counteract the harmful effects of radiation by reactive oxygen species scavenging, by anti-inflammation, by molecular targeting, by regeneration of hematopoietic stem cells, and by promoting the DNA repair and genomic instability. Next slide. So these radioprotectors and radio mitigators, we have some chemical substances, we have some natural origin substances also. Among the chemical substances, we have amifostin, which is an FDA approved drug. It has the activity of free radical scavenging or repair, and that is how it counteracts the toxic effects of radiation. We have other drugs like benzidamine, which prevents oral mucositis triggered by radiation therapy. We use it on a day-to-day basis. It is just that we do not know how it exactly is functioning, but benzidamine mouthwash counteracts. It's a radioprotector and radio mitigator. Likewise, we have drugs like glutamine, pentoxiflin, statins, meloxicam, even superoxide dismutase mimics. Several of these drugs which are from chemical origin, which act as radio mitigators. We also have drugs from natural origin like fig waste, grape seed extract, tea extract, vitamin A, vitamin C, vitamin E, even curcumin. All of these have radioprotective properties, and they will help in a significant way to counteract the effects of radiation. Next slide, please. Briefly about amifostin, which is an FDA-approved drug. So the pro-drug is WR2721, which in the presence of alkaline phosphatase gets converted into an active compound, active thiol, and this binds to the reactive nucleophiles and stabilizes the DNA. So when there is ionizing radiation, which causes increase in free radicals and upregulation of p53, this is how amifostin works. But why is amifostin approved? What is its preference over preference for healthy tissue over tumor tissue? It is because this alkaline phosphatase is present in abundance in the normal healthy tissue, and it is not present in a high quantity in the tumor cell. That is why this gets localized in the normal tissue and protects the normal tissue, and the radiation effect on the tumor cell will not be affected. So what is the elimination half-life? 15 minutes if we infuse the drug. The half-life is less than 10 minutes. It is that quickly acting, and less than 6% is excreted in urine. It is indicated in conditions like head and neck cancer, where we want to prevent xerostomia in post-op radiation, or even in ovarian cancer or NSCLC, when we want to prevent cisplatin-induced renal toxicity. Theoretically, it should also protect against parenchymal damage caused by radioactive iodine therapy or radiation-induced cystitis and dermatitis. Of course, amifostin has shown to be effective, but it is not used very extensively. Why? Because it has significant side effects also. Nearly 60% of the cases who are infused with amifostin have hypotension. They have diarrhea, drowsiness, hiccups, electrolyte imbalances. They have hypocalcemia, high chances of allergic reactions, cutaneous reactions like erythema multiforme, Stevens-Johnson syndrome, or toxic epidermal necrolysis, and rarely people may have loss of consciousness also. That is why the dose and side effects are balanced, and we have to identify individuals who are at a high risk of toxicity, and in them amifostin can be advocated. Next slide. These are the side effects that I have mentioned and the pharmacokinetic properties. The clearance is in 8 minutes. Next slide, please. So now coming to the main group of drugs, the radiosensitizers. How did it come about? When was it decided that chemotherapy and radiation given together will have an enhanced effect? So in 1979, Steele and Peckham introduced the theoretical framework of combining cytotoxic chemotherapy and radiation. So what was the framework that they introduced? Next slide, please. So it is based on spatial cooperation and in-field cooperation. So what is spatial cooperation? They postulated that radiation will have the local effect. It will cause local control, and chemotherapy will address all the micrometastasis or distant disease. They both will have their independent mechanisms of action, and they both will have their independent non-overlapping toxicities. This is what was their understanding. But this is not entirely true, because we now know that radiation and chemotherapy may have some overlapping toxicities, because of which we can use some agents and we do not use some agents. The other principle that they have postulated was in-field cooperation. In-field cooperation, which is happening at a tissue level or a molecular level, where the drugs may just have an additive effect with each other. They may have a supra-additive effect with each other, or they may have an infra-additive effect with each other. So how was this determined, whether this drug and this dosage will have an additive effect or supra-additive effect or infra-additive effect? Next slide, please. This is based on the isobologram. So on the x-axis and y-axis, we had drug doses and RT doses which were tested, which were graphed against each other. And the thick line in the middle is the line of unity. It is the additive effect, meaning they both have an effect which is adding without any synergistic or antagonistic effect. That is the line of unity, additive effect. So when we were charting the doses against the RT doses against the drug doses, if the graph is falling over that line, they had infra-additivity or antagonistic effect. And if they're falling under that, they had supra-additivity, additivity, or synergism. So based on this, the ideal drug dose and the RT dose were calculated, and it was postulated. Next slide, please. So now we have spoken about how radiation affects, how chemo and radiation will have a beneficial effect. So what are the benefits that we are looking for with chemo radiation? Organ preservation, tumor shrinkage, management of micrometastasis, non-overlapping toxicities with additive benefits, overcoming cancer resistance, and improving locoregional control and survival. Next slide, please. So how are these working? They are all working in tandem. So how are these working? So we have the process increased cell damage, where the drug gets incorporated into DNA or RNA, and thereby resulting in the damage of the cell. Radiation also is damaging, chemo is also damaging. This is the mechanism of action. Examples we have is 5-FU and cisplatin. Likewise, when they interfere with the DNA repair process, inhibition of DNA repair can be seen with antimetabolites, especially like 5-FU, gemcitabine, methotrexate. So when these happen, they will inhibit the DNA repair and they will enhance the radiosensitivity. Cell cycle interference. I have told you that one phase, G2M phase, is more radiosensitive and the S phase is radioresistant. So when radiation is addressing the cells in the radiosensitive phase, we are giving drugs which will hit the cells in the radioresistant phase. For example, taxanes and etoposide and antimetabolites. They will kill the cells which are in the G1S phase. The radiation will kill the cells which are in G2M phase. They will have synergistic effect and resulting in toxicity to the tumor. A reoxygenation. I have told that hypoxia is inherently radioresistant. So drugs which promote reoxygenation will automatically enhance the radiosensitivity. We have drugs like paclitaxel, tirzepamine, mitomycin C, nitroimidazole, all these which will facilitate this aspect. Cytotoxic effect we have with antimetabolites and EGFR inhibitors. They also block the pro-survival, the pathway. The EGFR pathway has pro-survival effect. So by blocking that, the survival is also inhibited. Immunomodulation and hyperradiation sensitivity. All these are mechanisms by which chemotherapy will enhance the effect. Next slide, please. Next slide, please. Yes, all these are mechanisms by which chemotherapy will enhance the effect of radiation. So it is not like one mechanism only. For example, 5-FU here has property of cell cycle interference. It has cytotoxic property also, and it has interference with DNA repair also. So not just one mechanism, with multiple mechanisms, chemotherapy will enhance the effect of radiation. Next slide, please. This is just a picture to show different drugs which are active in different phases of cell cycle, based on which we will select the combination and use them with chemotherapy for a beneficial effect. Next slide, please. Now, many of these drugs have been discussed in detail earlier in the previous classes. So I just highlighted the most important points, but I could not stop myself from discussing in detail about cisplatin. Just like Rajan sir said, cisplatin can never be ignored. So we have CDDP, cis-diamine dichloroplatinum, which when enters into the cell, it undergoes aquation. When it undergoes aquation, it will form positively charged platinum complexes, which react with the negatively charged DNA and form those adducts. And this is cell cycle non-specific molecule. Next slide, please. So it forms both interstrand crosslinks and intrastrand crosslinks. Which is more important? What is the major mechanism? So nearly 60% of the cases, it forms intrastrand crosslinks. And it forms them at the N7 or O6 sites of the guanine. And these intrastrand crosslinks are responsible for activation of apoptosis, inhibition of DNA replication, and thereby cell death. This cisplatin is active in both hypoxic as well as well-oxygenated cells. Next slide, please. So like I have told, cisplatin and radiation are effective due to enhanced formation of toxic platinum intermediates with free radicals, scavenging free electrons. Radiation induced increase in the cellular uptake. More drug is taken up into the cell because of the radiation effect, synergistic cell cycle disruption, and inhibiting repair of RT-induced DNA lesion. Next slide. The doses when we use with concurrent radiation, if it is weekly, it is 40 mg per meter square, IV, for one dose on day 1. In 2 weekly or 3 weekly regimens, we use 100 mg per meter square, and it is indicated in head and neck cancer, esophageal cancer, lung, cervical, bladder cancer. The resistance can happen to cisplatin because of increased inactivation by thiols, increased DNA repair activity, defect in DNA mismatch repair, and decreased drug accumulation due to alteration in cellular transport. Next slide, please. So very important, Even though it was discussed extensively earlier, I'm still mentioning this point. We need all the baseline investigations, including renal profile and electrolytes and baseline audiometry. It is a highly emetogenic drug, and we have to provide prophylaxis against acute and delayed emesis, hydration pre, during, and post chemo with normal saline, and electrolyte supplementation with potassium chloride and magnesium sulfate is imperative. Urine output has to be maintained, and if the fluid given is more than 2 liters, furosemide diuresis also has to be done. It can be given IV or IP. We are talking about IV here with respect to the radiosensitivity, and the solvent is normal saline. This is a tabular form which is showing the correct fluid correction and the electrolyte supplementation that we need to be giving. Next slide, please. We're well aware of the side effects of cisplatin. Where acute, we have nausea, vomiting, hypersensitivity reaction. And then delayed, which may happen within few hours to few days, is the electrolyte disturbances, myelosuppression, hypersensitivity reactions. And chronic, we have nephrotoxicity, ototoxicity, peripheral neuropathy, and gonadal toxicity. It has interaction with other drugs. Cisplatin may potentiate the effect of etoposide. And when used with other nephrotoxic drugs like aminoglycosides and amphotericin, it increases nephrotoxicity. Likewise, when used with other ototoxic drugs, it increases the risk of ototoxicity. It reduces the effect of phenytoin. Pyridoxine may reduce the effect of cisplatin, and we have to be careful with other renal excreted drugs. Next slide, please. So that was in detail about cisplatin. Now we have carboplatin. Now, carboplatin is also a platinum analog, which is having a square planar structure. So it is relatively more stable. It has the similar mechanism of action where it forms intrastrand and interstrand crosslinks. But because of the stability in its structure, it causes lesser side effects and lesser renal toxicity. It is a radiosensitizer, which is cell cycle non-specific. Next slide, please. It is moderately emetogenic, and we know that the dosing is based on Calvert formula. As renal excretion is via glomerular filtration, we have the Calvert formula, which is based on area under curve, and the GFR, which is calculated by Cockcroft-Gault formula. And based on that, we determine the dosage of carboplatin. Next slide, please. The side effects, again, acute, we have nausea, vomiting, hypersensitivity reactions. Delayed, we have myelosuppression. Thrombocytopenia can be seen significantly in carboplatin because it inhibits the JAK2 pathway. And electrolyte disturbances, hypersensitivity reactions, and rarely it can also cause posterior reversible encephalopathy syndrome. Chronic toxicities, again, to a lesser extent as compared to cisplatin, but they are there. The nephrotoxicity, ototoxicity, peripheral neuropathy, and gonadal toxicity. It is indicated in head and neck cancers, esophageal, gastric, and lung cancers. Next slide. So now we have talked about platinum compounds, cisplatin, carboplatin. In fact, oxaliplatin is also being studied as a substitute for cisplatin in individuals who are ineligible for cisplatin. It is still under trials and yet to come into common use. Now, the next group we are talking about is alkylating agents, in which we have an important compound, temozolomide. It gets converted into an active substance, MTIC, in the cell, and it causes methylation, the adduct formation. It is methylation of DNA at the N7 and O6 guanine positions, which results in double stranded break, and it is indicated with concomitant radiation in glioblastoma multiforme. Next slide, please. It has low emetogenic potential. Pre-medication is with 5-HT3 antagonist once daily, 30 minutes before temozolomide. I had to mention this because this is an oral medication which we give every day, and this drug has to be used without fail. Initially, we have to give it, but if the patient is not having nausea, it may slowly be discontinued later. But if it is persisting, he may use it every day. Dosage is 75 mg per meter square once daily, orally during the 6 weeks of chemotherapy. And we also have the adjuvant therapy for 6 months also, this 2 protocol. Additional supportive medication is very important because in these cases, opportunistic infections and pneumocystis jirovecii infections are quite common, or they are highly susceptible, because of which prophylaxis with cotrimoxazole or pentamidine is necessary. There is no hepatic and renal dose modification. The side effects, we have acute side effects are nausea, vomiting, hypersensitivity reactions, headache, anorexia, delayed GI disturbances, diarrhea, constipation, myelosuppression, opportunistic infections, as I have mentioned, alopecia, and rare but sometimes severe side effects are interstitial pneumonitis and hepatotoxicity. Next slide, please. Now coming to a different group of drugs that are used with radiation, the antimetabolites. We have a very important drug, 5-FU, 5-fluorouracil. So we know uracil as an important base in DNA, and this uracil gets replaced by 5-FU. Competitively, it replaces the normal uracil and kills the cells in the radio-resistant phase. So when the 5-FU is taken into the cell, it forms 5-FUMP, 5-FUDP, and then deoxy-UMP. And instead of the normal deoxy-UMP, this 5-FDoxy-UMP gets incorporated and it causes faulty DNA. And at the stage 5, FUDP, when it tries for the RNA formation also, faulty substance gets incorporated. So there will be faulty DNA formation, there will be faulty RNA formation, hence cell death will occur. And when the cells are trying to repair themselves after radiation also, this 5-FU will have the cytotoxic effect and will prevent the active repopulation. So this inhibits effective DNA repair after exposure to radiation. It is metabolized by dihydropyrimidine dehydrogenase in the liver. And if there is DPD deficiency, and if we haven't tested it and there is severe toxicity because of 5-FU, the antidote that is given is uridine triacetate, which will get incorporated in place of the 5-FU compounds and thereby help in repairing the normal tissue. So we know that there is 5-FU resistance in MSI high tumors. Why does this happen? What is the mechanism? So when at this point we have the 5-DUMP binding with thymidylate synthase, this abnormal complex is identified by the DNA MMR system, and that will trigger the apoptosis and cause cell death. So when there is MSI high or faulty MMR system, this recognition is impaired, because of which the effectiveness of 5-FU will be reduced. Next slide, please. It is a low emetogenic drug indicated in head and neck cancer, rectal cancer, pancreatic and hepatobiliary cancers. It is an irritant. It can cause coronary vasospasm. Especially in continuous infusions, it can cause vasospasm. We have to be careful. And we can give drugs like nicorandil, which will prevent this vasospasm. Arrhythmias can happen, stomatitis can happen in these cases. Delayed, we have GI disturbances, we have diarrhea, myelosuppression, mucositis, to a lesser extent palmoplantar erythrodysesthesia. Ocular toxicity can happen in these cases. Rare but severe complication is acute cerebellar syndrome. Next slide, please. So these are the dosings in with concurrent chemo radiation. We have continuous infusion, 5-FU 225 mg per meter square over 24 hours on day 1 to day 5 for 5 weeks with radiation. Or we also have 5-FU plus leucovorin, where it is given as an IV bolus along with leucovorin for 4 days during week 1 and week 5 of radiation. Drugs that increase 5-FU efficacy and toxicity are allopurinol, cimetidine, fosphenytoin, gemcitabine, leucovorin, and metronidazole. So if we are giving these drugs concurrently, we should be careful about the dosing. Next slide, please. Now talking about another antimetabolite, capecitabine, which is an oral formulation, which when given will undergo these series of enzymatic changes and get converted into 5-FU in our body. This is indicated in rectal cancer and has the similar side effect profile as compared to 5-FU, because it gets converted into 5-FU in the body. Apart from that, it also has adermatoglyphia. The fingerprints are lost. And hand-foot syndrome, for which urease-based creams and diclofenac gel can be used. Next slide, please. So this is one drug that I wanted to mention, S1, which is a combination of tegafur, gimiracil, and otoracil. The reason for mentioning this drug is in individuals who have DPD deficiency, where 5-FU or capecitabine cannot be given. There are trials which are testing out this drug along with concurrent chemoradiation. So tegafur is a prodrug for 5-FU, and gimiracil, which is CDHP, it is a reversible inhibitor of dihydropyrimidine dehydrogenase. By inhibiting its metabolism, it will potentiate the effect of 5-FU. And otoracil, which is potassium oxonate, preferentially localizes in the gut, and it will prevent the toxic effects of 5-FU in the normal tissues of the body. So the concentration will be high in the tumor cell and it will be low in the normal tissue, because of which it will be quite effective. This is still in trial. and its metabolism is not dependent on DPD. So even in individuals with DPD deficiency, this can be attempted and is being tested. Next slide. Talking about another important antimetabolite, pemetrexed, this induces cell cycle arrest in the G1S phase. As we have discussed, G1S is a radio-resistant phase. So when pemetrexed is given along with radiation, radiation addresses the cells which are predominantly in the G2M. The cells which are left in the G1S can be attacked by pemetrexed, which has an effect at the level of dihydrofolate and tetrahydrofolate formation. Glutamation increases the cellular retention and intracellular half-life of pemetrexed, as well as making the polyglutamate metabolites greater than 60-fold more potent in their inhibition of thymidylate synthase. Next slide, please. So next slide, please. This has low emetogenic potential, and B12, there seems to be some confusion in this slide. It has low emetogenic potential. It has B12 and folic acid supplementation and dexamethasone pre-medication. The side effects are myelosuppression, mucositis, rash, nausea, fatigue, and thrombosis. Next slide, please. This was the slide that was talking about the side effects of pemetrexed. Next slide, please. Okay, before we move to taxanes, there is another antimetabolite, gemcitabine, which is cell cycle specific, which works in the G1 and S phase and is indicated in pancreatic cancer and hepatobiliary cancers. So this takes care of the radioresistant cells. The dosage is quite varied. It varies between 125 to 800 mg per meter square. It is moderately emetogenic. It's an irritant with fever and flu-like symptoms when given. So when an individual presents within 1-2 days of administration of gemcitabine, we can actually attempt relieving their symptoms with anti-inflammatory medication. Only if it is persisting beyond that, we can look for other causes, because myelosuppression, which is also common in gemcitabine, doesn't happen that soon. Thrombocytopenia is also seen significantly with gemcitabine. Hemolytic uremic syndrome, transient elevation of liver enzymes are seen. Rarely, pulmonary toxicity or vascular microangiopathies may be seen. Now, talking about the next group, which is taxanes. Yes, taxanes, docetaxel, again, this is more effective in the G1S phase. They bind to the beta tubulin and stabilize the microtubules. So when the chromosome undergoes replication, when it comes to the center and then it undergoes that replication, and later they have to be pulled back before division into two different cells. For bringing the chromosomes towards the center, for enabling that replication and pulling them back, the microtubules are essential. When these taxanes stabilize those microtubules, the separation and division into two daughter cells will not happen. So there is interference with cell replication. This is how taxanes will act in tandem with radiation to potentiate radiation. Indicated with RT in head and neck cancers, which are cisplatin ineligible. The dosage is 15 mg per meter square once weekly, given for max 7 cycles. It has low emetogenic potential. Next slide, please. We have to be careful in these cases. We have to give pre-chemo dexamethasone 3 days and diphenhydramine 50 mg, because it has high risk of fluid retention as well as anaphylaxis. Post-chemo, analgesics for muscle cramps should be given. Docetaxel is a substrate for CYP3A4, so enzyme inducers and inhibitors may have a reaction with the drug. The use of non-DEHP plastics cannot be used for the infusion. Dose modification in hepatotoxicity is necessary. Acute side effect, irritation and hypersensitivity reactions. Delay, we have GI disturbances. They have significant diarrhea, mucositis, myelosuppression, fluid retention, alopecia, and cutaneous nail reactions also quite common with docetaxel. Rarely we see pulmonary toxicity and neuropathies. Next slide. Paclitaxel is another drug from the same group which has similar mechanism as docetaxel. It's indicated in esophageal cancer with a dose of 50 mg per meter square weekly dose. Acute, again, irritant and hypersensitivity reactions. Delayed, we have GI disturbances, myelosuppression, alopecia. Rarely we have pulmonary toxicity. Neuropathy is seen much more commonly with paclitaxel than docetaxel. Significant peripheral neuropathy can occur. Now, next slide, please. Talking about the next group of drugs, the topoisomerase inhibitors, we have etoposide, which is a semi-synthetic derivative of podophyllitoxins, epipodophyllitoxins. And this is cell cycle dependent and acts in the S and G2 phases. Where is this topoisomerase essential? It is essential during unwinding and rewinding of DNA. When the DNA before replication or during replication undergoes that unwinding process, it tends to break. So these breaks and nicks are repaired by the topoisomerase. So when we are inhibiting that, the DNA damage occurs, the replication is impaired, and the cell undergoes death. So radiosensitization in these cases correlated with the prolongation of radiation-induced G2 cell cycle arrest, interference with the replication and repair process. Next slide. Next slide, please. Etoposide is indicated in lung cancer at a dosage of 50 mg per meter square IV from day 1 to day 5, once every 4 weeks. Dose per cycle should not exceed 250 mg per meter square. It has moderate emetogenic potential and with a dose modification in hepatic and renal failure. As we can see here, it can be used in both squamous and non-squamous NSCLC as well as in small cell lung cancer. Etoposide is quite effective as a radiosensitizing agent in all forms of lung cancer. Next slide, please. Here we have the acute and delayed side effects. Hypotension is an important acute side effect. We have to be careful. Fluid correction has to be done. Myelosuppression, fatigue, stomatitis, and mucositis can happen in the delayed phase. Rarely, but severe complication is congestive heart failure and myocardial infarction. So we should be watchful. And pulmonary toxicity and acute leukemia also can happen as a long-term complication in these cases. Next slide. Now talking about another independent compound, mitomycin C, which is derived from Streptomyces caspitosis. It inhibits repopulation and repair of cancer cells during the RT. And this has preference to hypoxic cells also. So it is very effective that way. It is indicated in anal cancer at a dose of 10 mg per meter square as IV bolus on day 1 to day 29. Next slide. It is important to note in this mitomycin C that it is given in conjunction with other anti-neoplastic drugs like mitomycin plus 5-FU along for radiation or mitomycin plus capecitabine. Rarely mitomycin or cisplatin 5-FU can be given because the dose should not be more than 20 mg per cycle, and because it cannot be given at a much higher dose as a monotherapy, giving it in combination with another drug will be more beneficial. It is a potent vesicant, so we have to be very careful that the drug does not undergo vesication, and the antidote is DMSO. We have to follow all the vesication protocol if we identify the drug, and antidote application is also essential. Acute dyspnea and severe bronchospasm may happen in cases who are receiving mitomycin C, especially if they have received prior vincristine or concurrently if vincristine is being given, they may have this severe complication. We should be watchful and be prepared for proper supportive measures. Nausea and vomiting can happen in these cases. In delayed myelosuppression, which is a dose-limiting toxicity, fatigue can be seen. Hemolytic uremic syndrome can also occur in cases who have received mitomycin C. Rare but severe complication, we have interstitial pneumonitis, veno-occlusive disease, and acute leukemia. Next slide, please. Now, so far we have spoken about the chemotherapy drugs, which have effect on normal cells as well as the tumor cells. Now we are talking about more targeted therapies like the monoclonal antibodies. We have cetuximab. The rationale for administering cetuximab in cases in head and neck cancers is because of the EGFR overexpression that is seen. It is a pro-survival pathway. So when there is EGFR overexpression, it will have intrinsic radioresistance and poor prognosis. So if we are blocking this pathway, the pro-survival pathway, that will potentiate the radiation effect. This was the rationale, and it can enhance the radiosensitivity, leading to better tumor control indicated in locally advanced head and neck cancers. Next slide, please. So the dosing we have in cycle 1, first week, we give it at a dose of 400 mg per meter square, IV infusion over 120 minutes. And in the subsequent cycles, we give it as 250 mg per meter square. Dose modification is necessary when there are liver, renal, and hematological dysfunctions. And what are the things that we need to watch for? infusion-related reactions, because it is a chimeric monoclonal antibody. Infusion reactions, we should be extremely watchful. Interstitial lung disease, skin reactions, electrolyte abnormalities. In one of the previous classes, Bhavna madam has mentioned about the electrolyte abnormalities that she has seen in the cases. So it is important for us to be watchful about these. Fatigue, abdominal pain, and constipation can also happen in these cases. Next slide, please. Additional therapy, what do we give pre and post? So 30 minutes prior cetuximab infusion, we have chlorpheniramine, dexamethasone, and H2 antagonist, paracetamol. All these we have to keep them handy and administer them. Antiemetics as a take-home medication, we give metoclopramide when required. Initially, for the first 3 days, we administer, and later, based on their nausea, they can use. Gastric protection with proton pump inhibitors is necessary because they are at a higher risk of GI ulceration or bleeding. Next slide. There is another monoclonal antibody with a similar kind of mechanism, that is nemotuzumab, which can be used at a dosage of 200 mg weekly. The side effects are mucositis, skin reactions, neutropenia, vomiting, and diarrhea. So we have spoken extensively about the chemotherapy drugs. We have spoken about monoclonal antibodies, but now we are in the era of immunotherapy. So what is the role of immunotherapy with radiation? Next slide, please. So by the rationale, that was the 6th R, reactivation of immune system. RT can provoke an immune systemic response. This was the rationale for RT and IO. But do we have a thorough understanding of how these two interact? So there are certain points that need to be addressed. What is the interaction with RT and immune system? Is it totally synergistic, or is there some antagonistic compound? Which are the agents or substances which may cause that, which may cause this? So it still needs to be elucidated, but it is in the path. Identification of best schedules for RT and IO, expansion of the abscopal effect, and mechanisms to amplify the immunoradiotherapy effects. So these are all aspects which need further elucidation, but it is definitely in the pipeline because there are some trials, phase 1 and phase 2 trials, which have tried SBRT with immunotherapy in advanced hepatocellular carcinoma, or SBRT with durvalumab in NSCLC. And these phase 1 and phase 2 trials have shown significant benefit with the addition of IO to RT. So identification of these factors will help us use immunotherapy more effectively with radiation. Next slide, please. Now I've spoken so much about chemo and the effect of radiation and chemo in tandem. This is another interesting phenomenon that happens in individuals who have received radiotherapy, known as radiation recall. Please look at the list of drugs that are there which can cause radiation recall. We have actinomycin, adriamycin. We have monoclonal antibodies like bevacizumab, trastuzumab, immunotherapy drugs like pembrolizumab, nivolumab. We have drugs like osimertinib, tyrosine kinase inhibitors, chemotherapy drugs like etoposide 5-FU. Next slide, please. So what is the actual mechanism of this radiation recall? Because we are seeing drugs from so many different classes, having so many different mechanisms of action at a molecular level. Most commonly, we see that in doxorubicin, gemcitabine, capecitabine, taxanes, even non-cancerous medications like anti-TB agents and simvastatin have caused radiation recall. And these are mainly, the manifestations are mainly cutaneous or pulmonary, and they are independent of prior radiation dose. So whether they have received few fractions, they have received many fractions, it did not matter. And sometimes they can happen weeks to months after radiation. So how do we differentiate it from radiosensitization? We are giving chemotherapy drugs to potentiate the effects of radiation. So how do we know that this is not radiosensitization and it is radiation recall, which is given because of some other drug? So usually a 7 days is considered a reasonable cutoff. 7 days period to have the radiosensitization effects of the chemo or monoclonal antibody that we have given. Beyond that, we should suspect radiation recall. Next slide, please. We have the CTCAE grading. Here is a picture that is depicting the cutaneous manifestation of radiation recall. We have the grade 1, 2, 3, 4, 5 based on the extent of erythema, the desquamation, and where it is confined to, if there is bleeding that is present. Based on that, we have the CTCAE. So now we know that so many different classes are causing it. So what are the postulated mechanisms? It may be because of acute or chronic inflammation, because of the interleukins, TNF alpha, TGF beta, because of the keratinocyte necrosis, dysregulated release of reactive nitrogen and reactive oxygen species, dysfunctional stem cells, abnormal tissue vasculature, and impaired tissue repair. So all of these may have a role in radiation recall. So how do we treat it? Withdrawal of the trigger drug is imperative. First that, and then addressing the side effect with either topical or oral steroids, anti-inflammatory drugs, and antihistamines. And once it has settled, we can attempt reintroduction of the drug. We can re-challenge with a lower dose and see for the effects, or change of the drug can be attempted. This is in brief about the different kinds of drugs that interact with radiation. I hope this was useful. Thank you.
Thank you very much, Meena, for that comprehensive presentation. The reason why I'm coming closer and closer to the screen time and again is because I was awestruck. You're basically not a radiation oncologist, but your understanding of the disease is mind blowing. So there are 2 or 3 things that we should all keep in mind. If you are to Google the dose of concurrent cisplatin, it will always say 100 milligram per meter square IV 3 weeks into 3 doses in head and neck. But I know of very few people who are able to pull off that dose. So we usually cap it at 50 milligrams and we give it weekly. It's more because of logistics. There was not a whole barrage of data which could support that. But of late, studies presented in ASCO 2022 by Professor Atul Sharma and TMH group, our dose has been validated. So if you're doing 50 milligrams per week, it's as good. Second thing is Pacific 4 is ongoing. Adjuvant durvalumab with SBRT. It's shown some PCR, some benefit, but as Meena rightly pointed out, it's still in the pipeline. And the drugs that we need to understand are cisplatin, carboplatin, mitomycin, 5-FU, temozolomide, and paclitaxel. So the issue is, if you go back to the original cross trial, the median weight of patients in that trial was around 62, and we almost never get to see a 62 kgs esophagus. So if we are not giving a doublet in that and we are restricting ourselves to a single agent, be it a taxane or a platin, we are justifying our stand. And most importantly, there is a set time duration in which you have to deliver radiation after you've given the drug. So that has to be kept in mind. Rest, it's up to boss, Dr. Chetan, to analyze and scrutinize the examinees. Thank you so much, Meena, once again.
Thank you, sir. Thank you for the kind words.
Thank you. Thank you, Dr. Rajan, for those kind words. And maybe now have the Viva questions. First of all, I'd like to compliment Dr. Meena. In fact, I had messaged her personally that it was probably one of the most comprehensive presentations on chemoradiation. Really excellent, right from the basics to the drugs. And I can really just imagine the amount of time you've put in. And that is really very, very kind of you. That is really very helpful. And as messaged earlier, please allow us to use it for our presentations for our students as well. It was a very, very good PowerPoint presentation.
Thank you, sir. It can be used for students
so,
as you.
Thank you. Thank you. So, this is now we are going to have a Viva session. Most of the questions will be based on whatever has already been discussed. And this will just be a case-based Viva, so that these are some situations which we face very often in our day-to-day practice. And let us have them from on the screen. Is it okay to show them from your side?
From
Can you
Yes,
show
sir.
them
We'll
from your
display that,
side?
sir.
Yeah. So the very common situation, it's a 55-year-old gentleman who's been a smoker with alcohol abuse, hypertensive. He's come with a painless mass on the left side of his neck with intermittent nosebleeds and some difficulty in swallowing. And the neck mass is actually a lymph nodal mass, which is about 2.2 by 1.5 centimeter. And at least nostril examination does not show any abnormality. The cranial nerves and all visual fields are quite okay. So based on this history, what kind of investigations would you like to have? May I have the first examinee? It's Dr. Richa,
Yes, sir.
right? Yeah, please go ahead. So what do you do when you have such a situation?
Sir, I would like to get a imaging done, MRI.
What imaging?
Sir, contrast enhanced MRI of the face and neck, and
Okay.
sir, ENT evaluation for nasal endoscopy, and
Yes. Yes. So as the history is quite, yeah, please. Go ahead. You want to say something? Go ahead. Is that all? Okay. So as the situation looks quite obvious that there is probably a mass in the nasopharynx, which is why the patient is complaining of nasal bleeding, and he also has presented with neck nodes, which is a very common presentation of nasopharyngeal carcinoma. So the biopsy was done as advised, an ENT examination was done, and nasopharyngoscopy revealed a mass which was biopsied, which showed well-differentiated non-keratinizing squamous cell carcinoma of posterior nasopharynx. Do you do any additional molecular or genomic testing? Based on this, morphologically, the pathologist is very sure that it is a squamous carcinoma of nasopharynx.
Yes, sir.
Yeah, Dr.
Hello.
Satyam, please go ahead. Yeah.
Yes, sir. Sir, I would like to do EBUR by EASE. And
okay. So you'd like to do EBV studies? Yes.
EBV by DNA quantitative.
Why do you want to?
So EBUR by EASE is a diagnostic marker for Epstein-Barr infection, and nasopharyngeal carcinoma is most common in EBV. And EBV by DNA for diagnostic and prognostic for diagnostic and prognostic value. So I would like to do both tests.
And how does that change your treatment?
So if EBV DNA more than 4,000 copies, so consider as a high risk, and in this case we can give concurrent means RT with chemotherapy, and also we can monitor.
EBV, are you going to decide your concurrent regime based on your EBV status?
So stage 1, stage 2 divided into low risk versus high risk. If EBV DNA more than 4,000, so it considered as a high risk. In this case, concurrent chemo with radiation have benefit. In advanced stage, ideally concurrent, so induction chemo followed by concurrent chemotherapy is ideal.
So Dr. Richa, what is your induction? Do you have any protocol for induction for this patient? Or would you like to go ahead with direct concurrent chemoradiotherapy?
Sir, it is T2N1 stage 2. So directly we will go for chemoradiotherapy. For advanced T4, T3 and T4, we go for NACT. GEMS is braced for 3 cycles, then CTRT. So in this patient, given that it is a stage 2, I would like to go for CTRT.
Okay. And what do you plan? What is your commonest go-to regime for concurrent chemoradiotherapy?
I'd like to plan GEMS.
Sir is asking about concurrent.
Sorry?
No.
Sir, cisplatin.
Yeah, go ahead. Yeah, that's what I was just asking. So you want it to be, so you want to use gemcitabine in the neoadjuvant setting or concurrent setting?
Sir, gemcitabine with cisplatin in neoadjuvant setting, and weekly cisplatin when I'm giving it with IMRT.
Yeah. So there was some talk about Dr. Rajan just mentioned about cisplatin 100 milligram per meter square, and I think we have data from 2 studies, URTC studies, where that was actually the only regime which showed improvement in survival. But the grade 3, grade 4 toxicity percentage was almost doubled, 34 versus 77%. So in most of our population where nutrition is a big problem, not many people are very keen on having a gastrostomy tube. The dietary counseling sometimes is lacking, or dietitian consults are not opted often for our patients. It becomes a little difficult to give that kind of regime and maintain the nutrition. And if the patient's nutrition suffers, then these people are going to have a tough time on chemoradiation. So that is probably the reason why we have shifted to a regime. And there is some data from TMH that if you end up giving 200 per meter square of cisplatin over a period of 6 weeks, it's still okay, whether you give it 100 per meter square 3 weekly or in divided doses, it's still not bad. So probably weekly regime is not the best, but the most practical regime in our situation. May I have the next slide? Yeah, so that was those were the imagings which you wanted, a scopy, MRI of the head and neck, and of course a whole body PET scan is always better if you have it in your institute, so that there are no surprises at a later date. Dr. Satyam rightly mentioned that he would like to have e-birth studies, and a high EBV DNA copy number is going to be a high risk feature. So for stage 2 disease, Dr. Richa would like to go ahead with concurrent chemoradiation. Well, you may offer this, if the node is bulky, you may offer the patient a neoadjuvant cisplatin with gemcitabine, or at some institutions, the protocol may be docetaxel platinum with 5-fluorouracil. And remember that this is a highly hematogenic protocol, TPF, your cisplatin dose for even concurrent regime. If you are going to use 100 per meter square regime, it's a highly hematogenic drug, and you are going to need a 4-drug anti-emetic regime. Next slide. Yeah. So for any cisplatin dose, which is going to be more than 80 milligram per meter square, you need to pre-hydrate with at least a liter of saline. Remember, the cisplatin should be given again in a liter of sodium chloride, and post-hydration, the total fluid volume has to be to the tune of 3000 ml, and with replacement of potassium and magnesium as well. The same is true for any cisplatin more than 60. This would be the regime. For doses lower than 60 per meter square, probably you can cut it down but not by a big margin. And even cisplatin of less than 40 per meter square, you still need to give the patient at least 2000 to 2500 ml of fluid. So maintaining hydration for cisplatin, especially in the concurrent setting when oral intake is compromised, is absolutely important. Next slide. So what are the high-risk features for adjuvant radiation? You said that, well, this may not be the situation for neoadjuvant chemo. For a nasopharyngeal carcinoma, the matter is rather straightforward. But even for oral cancers, carcinoma of tongue, carcinoma of buccal mucosa has been operated, and these patients may mandate adjuvant radiation. So which are the situations where you would like to give adjuvant radiation? Dr. Satyam, can you take it?
Absolute indication, margin positivity, and extraneural extension.
Sir is asking about adjuvant radiation.
Adjuvant radiation.
And
not definitive.
Okay. Node positive,
okay.
LVI, PNI present, and higher tumor stage means more than T2, and
okay.
Depth of invasion more than 5 mm.
Yeah. So depth of invasion is also an important factor. Depth of invasion, neurovascular invasion, node positivity status. Any node positivity, or you need some specific number? One
Any
node,
node,
two
sir.
node,
Any node, sir.
any node, yeah. So that's important, that any node positivity makes it a high risk situation. So you would like to offer adjuvant radiation to these people as well. Now, actually, for node positive disease, there is data for adjuvant chemoradiotherapy, but we'll come to that later. Now, there are patients in whom there may be issues with creatinine, and cisplatin administration may be a challenge. So can you substitute carboplatin with cisplatin? Dr.
Yes,
Richa, please go ahead.
Yes, sir. We can substitute carboplatin, and with in some places like CA ovary, carboplatin is equal efficacious than as cisplatin.
So can you substitute carboplatin for cisplatin across all malignancies, or it's only for ovarian cancer or some select cancers?
Sir, if the patient is cisplatin ineligible, then I can substitute carboplatin.
Okay, so cisplatin ineligibility is one thing, but carboplatin, administration of carboplatin is relatively easy. The shorter infusion. You substitute carboplatin and cisplatin with equal efficacy. Are you happy with the efficacy, or cisplatin is the drug?
Sir, when cisplatin compatible patient is there, then cisplatin is preferred over carboplatin. And if by any chance the patient is ineligible, like nephrotoxicity or peripheral neuropathy or NYHA grade 3 or more, then I can prefer carboplatin. Only thing in carboplatin is that it is having more hypersensitivity.
The point I was trying to make is probably cisplatin and carboplatin cannot be used interchangeably in all malignancies, but only in select malignancies.
GCT and bladder cancer. Cisplatin is superiority compared to carboplatin.
Correct. So how do you administer carboplatin, Dr. Satyam? You must have given it thousands of times.
So, sir, in D5, 250 ml NS, 250 ml D5, ideal solution.
So why not suppose sometimes while administering, somebody makes a mistake and puts it in normal saline. Can it be given?
So chloride ion in normal saline can with carboplatin generate oxygen release species, and because of that drug degradation occur. So this solution became ineffective, and isotonicity also with more D5 compared to NS.
Fair. So as Dr. Richa rightly said, that patients on carboplatin sometimes can develop infusion reaction. Now, for example, this patient during the 4th week of infusion developed flushing, dizziness, there was pruritus. So a very classic infusion reaction. And the possible cause is carboplatin. Can we re-challenge the drug? Can we restart the drug?
Sir,
yeah, Dr. Richa, go ahead.
Ideally, we should not restart the drug, but we can re-challenge it by a reaction protocol, where we have to divide the drug in 3 parts, 1%, 10%, and 89%. And we have to first give 1% solution, then 10%, and then 89%, and be alert and watchful during the infusion.
So carboplatin is notorious that it usually starts giving a reaction only later, unlike paclitaxel, where it's often during the first dose or so, and once the patient tolerates the first dose, usually reactions in the infusion reactions that subsequent courses are not so common. But carboplatin typically will not produce an infusion reaction to begin with. As the number of cycles progress, and especially in the recurrent setting, if you've used it, be very careful that carboplatin is going to cause some trouble at some point of time. May I have the next slide? So Dr. Satyam rightly mentioned that adverse pathological features like extranodal extension, positive margins, close margins, node positive disease, T3, T4 tumors, perineural invasion, lymphovascular invasion, these are definitely indications for giving adjuvant radiation therapy for patients who've been operated for head and neck cancer. And in nasopharyngeal carcinoma, ovarian cancer, and non-small cell lung cancer, you can substitute carboplatin and cisplatin with each other. We use carboplatin in 5% dextrose because that gives a more stable structure, and hypersensitivity reaction is going to be a challenge. You can try it with antihistaminics or steroids and start a desensitization protocol like we use for oxaliplatin, but it's best to change the drug if possible. And thrombocytopenia was a major problem in concurrent radiation, especially in the cross protocol, where carboplatin was used along with paclitaxel. Next slide, next question. So it's a 60-year-old gentleman with 25 pack year smoking history, hemoptysis, decreased breath sound in the right lower lobe with no neck nodes. A chest scan showed a lesion in the right lower lobe with prominent right hilar lymphadenopathy. So what do you, how would you like to go ahead investigating this gentleman further? The diagnosis looks pretty straightforward. Okay, we know that it's most likely going to be a lung carcinoma. So what would you do? Dr. Satyam, go ahead.
So, sir, for firstly for staging investigation for diagnosis, so by bronchoscopy or followed by biopsy, and for staging investigation, PET CT scan and MRI brain with contrast, and for mediastinal staging, EBUS with transbronchial needle aspiration also indicated in early lung cancer.
Do you do MRI brain for all patients or only in symptomatic patients?
So if curative intent, so in all patients in curative intent to rule out the distal metastasis.
Yes, I think it makes perfect sense because almost 20% of brain mets in lung cancer may be asymptomatic. So if you're planning aggressive local therapy, it makes more sense in having a brain evaluation beforehand and then going ahead with it. Dr. Richa, what about the mediastinal evaluation? Dr. Satyam mentioned EBUS. Do you agree with it, or you have some additional
So we
strategy
have
for it?
to go for mediastinal evaluation in all patients only if it is T1N0 and peripheral tumor, then we can avoid mediastinoscopy.
So this is
Otherwise,
not T1N0. This is a big tumor. The patient already has right hilar lymph node. So there
so
may
in
be a
this
chance that
patient,
there
we
is.
will not need. PET scan will be sufficient.
Okay. And suppose this patient now does not have any metastatic disease. It's essentially a lesion in the right lung with some hilar lymph nodes. So what is your plan of action, Dr. Satyam?
So, sir, this is T2 N1 disease.
Yes.
So, I would like to consider for perioperative chemo plus immunotherapy, and
Okay.
followed by surgery.
And if surgery is not feasible?
So then definitive CTRT.
Would you like to involve the surgeon from the beginning, from day
Yes,
one?
after an MDT discussion, all this I plan.
Yeah, suppose now, Dr. Richa, this patient refuses surgery. He says that, well, I'm scared of surgery. I am not very keen. Give me an alternative strategy. And Dr. Satyam has suggested definitive chemoradiation. So does your choice of drug change, whether it's adeno, squamous,
Yes,
small
sir.
cell?
So depending on the IHC report, we will plan CTRT with either if it is adeno, then pemetrexate carboplatin, and for squamous, paclitaxel carboplatin, and followed by 1 year consolidation durvalumab.
Of course, that we'll come to that later. For small cell, do you have an alternative strategy or it's the same?
So we can also use gemcitabine with cisplatin.
For small cell?
No,
I
sorry,
meant
for
small cell.
squamous. For small cell cysito.
Yeah. Squamous cisplatin with T2%. May I have the next slide, please? Yeah, so this gentleman had undergone an endobronchial ultrasound with transbronchial needle aspiration, and IHC whole body PET scan was done. There was nothing there. So for inoperable patients, obviously concurrent chemoradiation with the regimes rightly mentioned by both these people, and the toxicity of this. Can you go back one slide, please? So toxicities of chemoradiotherapy, typically, now this is going to be largely a mediastinal with lung radiation. So what kind of toxicities do you encounter for these patients? Dr. Satyam.
Sir, pneumonitis, esophagitis are more common, and also mucositis.
Mucositis. Yeah. Dr. Richa, anything, would you like to add anything?
Dermatitis also, sir.
Esophagitis,
Next slide.
pericarditis.
Yeah, next slide. May I have the next slide, please? Yeah, so mucositis, yeah, no, just go back one slide. Go back one slide. Yeah, so mucositis, esophagitis are important, and of course, subacute toxicity in the form of pneumonitis also needs to be looked into, especially when later on you're planning to use immunotherapy as a maintenance strategy for a year. And for late toxicity, fibrosis, or even fistulas can be a rather troublesome situation. May we have the next question, please? Yeah, so this is a 50-year-old gentleman who's come with a fairly big rectal mass, 6 centimeters, which is clinically T3, and there are some perirectal nodes as well, but no metastatic disease on extensive evaluation. So let's not go into what kind of metastatic disease workup we are going to do. Dr. Satyam, this is a gentleman who obviously has a locally advanced rectal carcinoma. What is your standard management strategy for this patient?
So locally advanced rectal adenocarcinoma. So I would like to do first MMR by ISC and C level, and after I would like to give a long course RT with 5U plus 5U based regime, long course RT with.
Why would you like to do an MMR by IHC at the beginning when the patient is not metastatic and bulky?
So
is it going to change your plan of action now?
Yes, sir. So 3 to 5% rectal adenocarcinoma have DMMR or MSI high status. And in this case, we can directly give immunotherapy 6 months and followed by we have wait and watch approach in this DMMR and MSI high case.
Yes. So our standard drugs may not work so well in these tumors, and probably immunotherapy, we all know the dostarlimab story very well. So you would like to have that information beforehand. Great. So why, Dr. Richa, I think Dr. Meena had very clearly mentioned that in MSI
Yes,
high situations, 5FU does not work. Can you just recap it for us?
Yes, sir. Sir, 5FU is effective because it causes DNA damage, and when MSI is high, so the pathway.
How does it cause DNA damage?
Sir, by UTP.
What kind of which class of drugs does 5FU belong to?
Sir, anti-metabolite. It acts on
the
the
name
S
itself
phase.
suggests that it's. Dr. Satyam, do you have a different?
Yes, sir. So 5FU actively convert into fluorodeoxyuridine.
Which class? Let's first get the class of drug. Which class of drug does it belong to?
Anti-metabolite.
Okay.
And
go ahead.
5FU actively converted into fluorodeoxyuridine monophosphate and bind with thymidine synthesis and inhibit uridine monophosphate to thymidine monophosphate conversion and ultimately inhibit DNA and RNA synthesis. So if MMR protein is sufficient, so this defective cell easily means go into apoptosis pathway by this MMR protein. But if MMR protein deficiency, so apoptosis not effectively seen in MMR deficient patient. Because of that, 5FU is ineffective in MSI tumor.
Okay. So you mentioned that you do MSI testing for all your patients. Do you also do a DPD testing for all your patients?
No, sir. Not in elderly patient, we do, but in not all patient.
Why not? Because the by the time your radiation planning takes place, you can always get the result. The turnaround time is not very long, and unfortunately, there are no clinical markers for DPD deficiency.
Yes, sir.
So why only in elderly? I'm just asking. This is merely out of curiosity. Nothing.
So there is a 2 to 8% chance of DPD deficiency, and because of that, so if elderly patient and DPD deficiency, we give 5FU, there are more toxicity or more comorbidity compared to means younger patient. Ideally, we should do in all.
May
but
I have the next slide, please? Yeah, so I agree with your plan that chemoradiation, either long course or short course, or probably even total neoadjuvant therapy, you finish every therapy and then send a patient for surgery. The long course, short course can be debated depending on the patient's situation. You rightly said that MMR system recognizes 5FU, which is incorporated and triggers apoptosis. So this system will not work if there is a deficient MMR. Right now, with chemoradiation, we really don't give immunotherapy. We don't have very good data, but we can give only immunotherapy and probably hope that these patients are going to be will not require any further therapy. But the number really is very, very small. Our population of MSI high tumors or deficient MMR tumors is less than 5% in across all centers. So probably it's going to be limited for very, very few patients. DPD testing, yeah, that's a big puzzler what to do, because we don't have any clinical attributes to decide what kind of patient may have a deficient DPD. And if you have what kind of toxicity is seen in these patients? Dr. Richa, can you elaborate a little more on DPD deficiency patient by mistake has received, or you've given 5FU or capecitabine to these people and we don't know their DPD status and they are deficient. What kind of
Sir,
toxicity is
severe intractable diarrhea
and
myelosuppression.
yeah. So severe mucositis, severe diarrhea, prolonged myelosuppression, these are very common toxicities. In fact, sometimes the patients can have fatal complications of these things. So it may be a good idea to do it since it's now easily available. And if you have, especially if you have time on your side, by the time your radiation planning and all the other things happen, it may not be a bad idea to get DPD testing beforehand so that you know what you're dealing with. If it's a heterozygous type, you would rather give a reduced dose or maybe substitute it with something else, maybe a lower dose of capecitabine. If it's homozygous, you're not going to offer any 5FU based regime. Probably you'll try to talk to the radiation guys and get the RT dose optimized. There is study of TAS 102, but that is still not out. So we'll probably get that data a little later. Next slide. So now this is a different situation. It's a 61-year-old lady who's come with anal pain, and there is on examination, again, a big mass in the anal canal, just distal to dentate line. It's a squamous carcinoma. So classic anal carcinoma, T3N1, again, some perianal lymph nodes are seen. So what is a standard treatment option for anal carcinoma at your place? Dr. Satyam.
So definitive CTRT, so 5FU plus mitomycin-based chemotherapy with radiation therapy.
Yeah, so that's very important because in anal carcinoma patients, the first plan of therapy should be definitive chemoradiation. Otherwise, these patients often land up with surgery and then a permanent colostomy, which is definitely going to be very detrimental for their quality of life. So the first option has to be given as definitive chemoradiotherapy. Dr. Richa, how do you start chemoradiation for patients with anal carcinoma? Do you agree with the drug plan of mitomycin with 5-FU, or you have some different strategy?
So mitomycin 5-FU, mitomycin used in a dose of 10 mg per meter square, day 1, and 5-FU 1000 mg per meter square, day 1 to day 4, and then day 29 to day 32.
Okay. So this is something again which needs to be
with
yeah.
50.4 gray radiation.
Yes. So the dosing is not once every 21 days like many other regimes. It is once every 28 days because mitomycin can cause a prolonged cytopenia. So one needs to be very careful about it. Any other side effects of mitomycin? See, Dr. Meena's lecture had the side effects very well listed, but Dr. Satyam, can you just reiterate them for us?
So mostly, sir, extra recession and other GI toxicity, myelosuppression in hemolytic uremic syndrome, and pulmonary toxicity also common with mitomycin C.
Yeah. So you give mitomycin alone or mitomycin with 5-FU?
Mitomycin with 5-FU.
With 5-FU, because the combination has shown better results with compared to single agent. So that's a fair plan. When do you assess the response? A patient is actively on radiation. Patient has just completed chemoradiation. When do you assess the patient for the disease status evaluation?
After
Dr.
6
Richa?
months of radiation completion, because there is delayed response.
Absolutely. So you need to counsel the patients that these drugs are known to have a delayed response. So typically response assessment happens after 6 months or 24 weeks. And that is the time when you'll get maximum response. Now, in spite of aggressive chemoradiation, best radiation techniques, there are still some patients who will have locoregional failure. Dr. Satyam, how many patients do you see who don't do so well and at the end of the CTRT and 6-month protocol continue to have local disease which is symptomatic?
So, sir, it's depend on nodal status. So, if node negative and we give definitive CTRT, so around 15 to 20% chance of locoregional failure. And if node positive and T3, T4 tumor, so 30 to 40% chance of locoregional failure.
Yes, there is a fairly high chance of locoregional failure, especially in bulky tumors. Dr. Richa, what is your strategy for patients who have locoregional failure after primary chemoradiotherapy?
Sir, we'll get a repeat biopsy done, and then we can plan for other second line therapy like Folfox.
Or surgery?
Surgery.
Right. Yeah, or surgery,
Yes,
because
or surgery.
otherwise, if it's going to, if there is residual disease and which has not responded to your aggressive therapy, you will probably need to get it out, and the patient goes on a permanent colostomy. At this point, the reason why I'm reiterating this point is most surgeons feel that every anal canal carcinoma, the moment it's a small growth, they knock it off doing an abdominal perineal resection, which should not be the case. If it is a squamous carcinoma, we have to push it for chemoradiation. We are going to salvage 70-80% of the patients, and they can go home with a preserved anal canal, and which is and they can avoid a colostomy, which is very important for their quality of life. Next slide. Yeah, so we discussed that concurrent chemoradiation with mitomycin 5-FU or capecitabine or cisplat 5-FU in some patients also can be offered with radiation therapy, and the regimes are listed thus. Next slide. Yeah, vesication, myelosuppression, HUS, pulmonary toxicity, rightly mentioned by Dr. Satyam that these are common toxicities, and regression, as Dr. Richa rightly said, that usually regression is noted up to 26 weeks. So that evaluation should happen only after 6 months and not earlier, because earlier you may end up saying that the treatment hasn't worked and go on salvage therapy unnecessarily. Local regional failure rate is about 30%. Next slide. So, sorry, before we begin the next question, so how do you treat your extravasation? Dr. Satyam.
So to stop infusion immediately and aspirate as much possible fluid via Vigo, and then remove cannula and limb elevation, cold compression every 15 minutes, and to use specific antidote, dimethyl sulfoxide topically, sir.
Dr. Richa, do you apply cold compress for every extravasation, or do you use different temperatures for different extravasations?
So we apply a different for different temperature. So we apply different temperature for different drugs. We apply Vinca. For Vinca, we apply hot compressions, and for Adria, cold compressions.
Right. Any other antidote? DMSO is very difficult to procure, and it usually is stored as a frozen drug. So getting it by the time you thaw it and getting it to your wards is a little tricky. It's not an easily available drug. Do you have anything else apart from DMSO? Any other drug which can be used? Okay. Hyaluronidase?
Sir, hyaluronidase can be used for a local site application
Yes.
to
Yeah.
reduce the absorption.
There was actually, when I was at TMH, Dr. Parikh sir had published a paper on an oral drug, which was a combination of trypsin, bromelain, commercially available as Flogam, and it had shown very good results, especially in the long term, that these patients, after their local therapy was over, we used to put them on this oral tablet for varying periods between 2 to 6 months, and it did these patients had a good response to it. So that drug is still available, and the only problem is it causes gastritis, but otherwise it's a good remedy as well. Anyway, coming to the next patient, he's a 68-year-old gentleman who's a diabetic hypertensive. He's got dysuria and hematuria with some suprapubic tenderness. They did a cystoscopy, found a 3-centimeter tumor in the bladder neck. They did a removal of the tumor, excision of the tumor, which showed high-grade urothelial carcinoma. There is invasion into the lamina propria, but the muscle muscularis propria is not identified. So we don't know whether it's muscle invasive or not. So how do you deal with this kind of a patient? Dr. Satyam, this patient has come to you with this biopsy report. There is no muscle invasion. The tumor has already been excised. How do you go about managing this patient?
So, sir, this is a PT1, PT1 and non-muscle invasive bladder cancer. So,
how do you know it's non-muscle invasive? The muscle bit is not included.
So no muscular propria identified, they mention. This is considered as a high risk. This is considered as a high risk, and I would like to do repeat TUBRT after 4 weeks and to check for muscular propria involved or not. And still, if muscular propria identified, so converted into T2 and muscle invasive bladder cancer, and then I would like to advise radical cystectomy.
So, he's a 68-year-old gentleman, diabetic, may not like to do a repeat cystoscopy so soon. This is something which we see in day-to-day practice. You tell a patient, go in for another cystoscopy, the cost involved, the trouble involved, plus you're going to put in a scope up a diabetic patient's urethra, you're going to introduce the chances of infection are there. Is there any alternative method to find out whether the patient has bladder, a muscular invasion? Okay, Dr. Richa. Yeah, yeah. Go ahead, go ahead.
MRI,
Sir,
sir.
MRI pelvis.
Yeah. So MRI can, it's not that it's 100% sure, but MRI can give you a reasonably good idea whether the muscle is involved or not. If there is obvious muscle invasion, there's no point in pushing the or there are nodes in the pelvis. There's no point in pushing the patient for a repeated cystoscopy. You would rather go on with the definitive therapy. Now, this gentleman, again, he's 68, diabetic. He's scared of a permanent cystostomy bag, or he's not very keen about such an aggressive surgery because he feels that there may be issues during surgery as well. What is the next step? He says he doesn't want radical cystectomy.
So we can go for CTRT.
Okay. And what do you use for CTRT?
Sir, 60 to 66 gray RT with concurrent cisplatin, 40 mg weekly, 40 mg
Yeah,
per
so
meter
this is
square weekly.
yes. So this is one situation where you would push for cisplatin and not for carboplatin, and that is where we need to know whether the patient indeed is cisplatin eligible or not. So there are certain criteria based on which we decide whether the patient can be given cisplatin. Dr. Satyam, what are those criteria? Any idea?
Sir, it's called Galaxy criteria. So in which if ECOG PS more than 2 or more than 2, NYHA grade 3 heart failure, and hearing loss more than grade 2, peripheral neuropathy more than grade 2, and EGFR creatine clearance less than 60. So considered as a cisplatin ineligible. All these.
Correct, correct. So these are Golgi criteria which are going to tell you whether the patient is eligible or not eligible for cisplatin. And if the patient has any of these features, then you would rather not go in for cisplatin. You'll have to look at alternative strategies. May I have the next slide? Yeah, so the preferred regime, of course, remains cisplatin. If not cisplatin, then the other options are with paclitaxel, docetaxel, 5-FU, capecitabine, or other drugs. But these are not very good options. The best regime remains cisplatin-induced cisplatin with radiation. But of course, we need to warn the patient that radiation to the pelvis may come with colitis, proctitis, and we need to treat this with appropriate therapies when the patient develops these problems. Next slide. So now this, we change the system. It's a 73-year-old gentleman with headache and history of fall, and the MRI reveals a large mass in the right frontal lobe. There is vasogenic edema. The neurosurgeon has done a gross total resection, and it shows a glioblastoma, IDH wild type, MGMT promoter methylated. So, Dr. Richa, how do you treat GBM at your place? Patient is a 73-year-old guy. The neurosurgeon says, well, I've removed most of the visible tumor. What is your standard treatment?
I will go for adjuvant chemoradiotherapy with the temozolomide, 75 mg per meter square, taken 1 hour before RT on all the days, and 70 gray RT.
Yes. Dr. Meena had mentioned some prophylactic medication, especially for this
for
drug.
PCP. I would like to start Septran for PCP prophylaxis and anti-emetic prophylaxis.
How do you monitor this drug on therapy, the patient on therapy?
So it is known to cause high myelosuppression. So weekly CBC has to be done.
Absolutely. The reason why I'm stressing this point is once the patient goes to the radiation department and patient is started on a tablet, he may or may not come back to you. The patient needs to be told that this drug has potential to cause severe myelosuppression. We've burnt our fingers at times when the patients have not complied or not checked their blood counts regularly, and they come back with very severe myelosuppression. So this is something which has to be monitored. May I have the next slide? Yeah, so you rightly said the standard is post-operative radiation therapy with temozolomide. You can continue adjuvant temozolomide for a period of about 6 months. Pneumocystis jirovecii prophylaxis with cotrimoxazole and weekly blood count, very important to monitor hematologic toxicities. Apart from this, it can also cause constipation, nausea, vomiting like any other oral drug, and some rash and weight loss. Next slide. So, we discussed this. So can we skip this? We already had a discussion on extravasation. Can we go on to the next question? Yeah. So again, this was discussed during the presentation. Can you identify the condition, Dr. Satyam?
So, nail changes, mainly blackish discoloration, and
Yeah.
mainly taxane-induced
Yeah,
nail changes.
darkening of. Okay. Very disfiguring. It may not cause pain, but it is sometimes very worrisome for patients who come to you with blackening of their nails. They are worried, especially young ladies are worried, and it may not look very nice. So you need to counsel them that this is a harmless drug effect, and once the drug therapy is over, their normal nails will come back. Next slide. Next slide. Yeah, so many of our common chemotherapy drugs can cause this problem: cyclophosphamide, docetaxel, 5-FU, Vinca, anthracyclines, so on. Next slide. Dr. Rajan, we are at 15:45. Please let me know how long we can continue. There are, I
I
believe, a
think
few more questions.
I think we can carry on for 10 more minutes, sir.
Great. Thank you very much. So, Dr. Richa, can you identify this condition?
Sir, this is photosensitivity. The sun exposed parts are having more skin reactions. It could be attributed to EGFR, cetuximab, or maculopustular rash is seen.
And apart from cetuximab, any other drug which can cause this kind of a problem? Commonly used drug?
Methotrexate 5-FU.
Yeah. Any other targeted therapies, Dr. Satyam?
Panitumumab. And
yeah. What about the
TGFR
oral
TKI.
TKIs?
TGFR, sir, osimertinib.
Yeah. So, this is a very typical situation that patients who are on either EGFR TKIs or EGFR directed therapies like cetuximab or panitumumab, these patients may develop this rash, and it can be very troublesome at times. The first and foremost is when you start these drugs, you need to counsel the patients, especially when you are sending the patient home with gefitinib or erlotinib, that this rash this can be a rash because of the drug. Most people believe that moment you get a rash, it's some kind of an allergic reaction, and they tend to stop the drug. So you need to counsel the patient that you need not stop the drug for a few pustules here and there. You can continue it if it is not very troublesome. You can use some local therapies, topical therapies to manage it. There was actually a very interesting meta-analysis in PLOS One a few years ago, a fairly big meta-analysis, 7,000 odd patients, for patients who were treated with EGFR targeted drugs. And they showed that worse the rash, better is the response. So people need to be told that don't worry about the rash. Even if there is a little bit of rash, please bear with it. There are medicines to control it, to reduce the symptoms, but don't stop the drug, because these drugs are, it is an indication that the drug is working well. So say a patient comes to you, Dr. Richa, saying that the rash is really very troublesome. It doesn't allow me to sleep at night. It's itching. And when I scratch, it bleeds. There are pustules. What do you do about it?
So first we have to stop the drug and
How
give
long?
Temporarily till the rash, till the severity is reduced.
Reduces in severity.
Yes, sir.
Yes.
And then, so we'll manage with supportive care like antihistaminics, local topical steroids,
Any
painkillers,
particular antibiotic you'd like to use for these patients?
doxycycline.
How much and how long?
Uh, so 500 mg twice a day for 7
500.
days. So sorry, 100
Mhm.
mg twice a day for 7 days.
Okay. Yeah. Okay. Yeah, because I don't think they have a 500 mg tablet for doxycycline. Yeah. Okay. Anyway, so the point is, please counsel the patient. Next slide. Next slide, please. Yeah, so this is an acneiform rash, which is commonly seen with all our targeted drugs, EGFR targeting drugs, and sometimes with chemotherapy drugs like actinomycin D. Patients need to be told about avoiding sun and heat exposure, use sunscreens, or as rightly said by Dr. Richa, you can use doxycycline to treat the severe drug rash. Next slide. May I have the next question? I think there is one more. Yeah. So, this was already discussed, radio protector drugs. Do you use them, Dr. Satyam?
No, sir.
No, because the availability itself is a big problem nowadays. Amifostem, once upon a time, was available. But a couple of companies were making it, but now I don't think it is very easily available. So I don't know what's the reason. Probably their efficacy itself was a big question that, especially when you're using high doses of concurrent chemotherapy, they didn't really protect from radiation-related side effects. Very few indications are there now. We were using them for preventing mucositis in head and neck cancers or patients, especially cervical cancer, for preventing nephrotoxicity. But as said earlier, it's not so easily available. Plus, these drugs also had some side effects: hypotension, hypocalcemia. Hypotension was particularly troublesome because these drugs had to be given subcutaneously. And then suddenly the patient used to collapse, and it used to create a big scare, especially in the OPD. Rarely patients also came up with hypocalcemia or diarrhea. That was another trouble. I think that is the last slide. Am I right?
Yes, sir.
Yeah. Thank you. It has been a wonderful time. Both you guys have really answered well. It was educating for me as well, and it was a great pleasure interacting with all of you. Thank you.
Thank you, sir.
Thank you, Meena, for being here, and thank you, Satyam and Rashmi. You did well, but as you realize, there is still a lot of brushing to do. Okay, so plus one thing for all of you, simple things first. If someone asks you about a cause of back pain, you don't say aortic aneurysm, you say spasm. So if you're asked about mucoepidermoid reactions, so you say Jeftinib first, you don't go to the higher molecules first. So common things common. So I was trying to bring you to that, but you took some time. And thank you, Karan, for having us all here. You're a 2D force, and no words enough. Like I said, I cannot say anything about Chetan sir. He's such a big person. Having him here in between us is an honor. And Meena, I find it hard to believe that she's not a MD in radiation oncology. So thank you very much. Thank you very much, Karan.
Thank you, Rajan sir. Thank you so
Thank
much.
you.
I mean, it was a pleasure having you, and thank you, Chetan sir, for accepting our invitation and taking this hard topic in a very delicate way, and Dr. Meena bringing out the intricacies of radiosensitizer, and also putting in a word for radio protectors, which was, I mean, really wonderful. And I think the attendees must have had a real pleasure of listening a perspective from a medical oncologist on radiosensitizers, and I think it was very, very interesting. I think we've learned a lot through this case-based question answer round, and I think a lot of things have been said. But as Dr. Rajan rightly said, that both Richa and Satyam, a lot of concepts needs to be revised for exams, and I think this video will be a benchmark for you to revise when you get back So
Yes.
I'll request you, since this is our last session, if you can scan this code and please give us feedback, because next season we want to come back stronger, and we want to also give some feedback to our examiners, so that next time they can be more more exam oriented. They have been giving us a lot of material, but what exactly is needed in the exam? So this feedback form will be very helpful for everyone. So any last words, Chetan sir, for the residents? Because then after this, they'll probably be submitting the thesis in August and appearing for exams in November.
I think they're good. They just need to brush up a little bit. And as rightly said by Dr. Rajan, the common things come commonly. So we need to look at those things first. And rest of the things, I think theoretically, I couldn't really find too many, nothing wrong in them. It's just rearranging their answer sequence of their answers, and that should be good.
Thank you, sir. Thank you. Rajan sir, any final comments from your side
No,
for the residents?
that's it. They were pretty good. The only thing that I wish to mention, I forgot it in between, is that career radiation oncologists attribute a dose of radiation to the dose of cisplatin. Like you and me know Umesh Mahansetti, he says that when you give a full dose of cisplatin, it's equivalent to giving 7 more grays, which is not possible otherwise. So,
yes.
And in head and neck, it's 9 grays. So when you give a complete dose of cisplatin all 6 weeks, it's like adding 9 more grays of radiation, which might, in my opinion, be the difference in having a longer duration of response or not. So cisplatin is the hero of medical oncology, even in era of CAR-T and immune checkpoint inhibitors.
Absolutely. And for those who are not from radiation background, the book is called E.J. Hall. And at the end of the book, there are 2 specific chapters on chemotherapy and the role of radiosensitizers. It's beautifully given there. The name is Radiobiology of Radiation. So those who are more interested can, see that book. If someone wants that, you can message in the group. I'll put it on the group.
We'll put a soft copy.
Yeah, we'll put it in the soft copy form and you guys can read it. And if you guys have any questions regarding any of the 18 series that we've done, you can shoot in directly or maybe on the group, and we'll try to handle those queries. If we can have a session again before the exams, we'll do that for you. So with that, I think we can conclude. And I would like to say thank you to Dr. Purvish sir, Dr. Prashant Mehta sir, also Amrita Icon, and all the teachers who've been gracious enough to be the examiners, moderators, mentors, and especially the speakers who have been the highlight of this series. And I thank all of you again, and all the examinees who've been very courteous, and at short times they've come in and filled in the gap. So thank you so much, everyone. And with this, we will conclude this session and this series. Thank you.
Thank you.